Welcome to the deep dive. Today we're plunging into something absolutely fundamental.
Nutrition.
It really is. It fuels everything.
We've got a great mix of materials today looking at nutritional goals, how our bodies actually use food, digestion.
And the guidelines too, like My Plate, Healthy People 2030, things people might have heard of.
Exactly. The aim here is to cut through some of the noise, There's so much information out there it can feel overwhelming.
Totally. So we want to pull out the practical, actionable knowledge, give you those aha moments without drowning you in technical jargon.
Right. Whether you're just curious about health or really looking to understand it better, this should give you a solid overview. We'll touch on needs across a lifespan, assessment, even cultural factors.
Let's get into it.
Okay, so first principles. Nutrition isn't just about managing weight, is it? Our sources frame it as way more foundational.
Oh, absolutely. It's the basis for growth, repair, metabolism, keeping organs working, basically everything.
And it's sobering to think about food security. The USDA points out it's a real issue. Even here, it is. And lack of reliable access to good food, well, it directly impacts health outcomes. You see things like longer hospital stays mentioned. It's a serious connection.
That lack of resilience you mentioned makes sense if the building blocks aren't there consistently.
Precisely. Which is why things like medical nutrition therapy, MNT, are so important.
MNT, that's like using diet as a specific treatment.
Exactly. For managing diseases like type 1 diabetes or using specialized support like enteral tube feeding. For severe conditions like inflammatory bowel disease, it's targeted nutrition.
And current standards really push for optimal nutrition too, right? Like the American Cancer Society, American Heart Association recommending low-fat diets, limiting red meat.
Yeah, those broader guidelines aim for prevention and general health.
Which brings us neatly to Healthy People 2030. It sets some pretty clear goals for the nation's health.
It does. Healthy People initiatives, going back decades, aim to promote health and prevent disease. The 2030 goals are the latest iteration.
So what are some specific nutrition targets in there?
Well, things like reducing obesity, adults and kids, increasing fruit, vegetable, whole grain intake,
And cutting back.
added sugars, saturated fats, sodium, the usual suspects, you could say, but also addressing food insecurity in children, boosting breastfeeding rates, really specific objectives.
The challenge, I suppose, is always turning those big recommendations into everyday habits for millions of people.
That's the constant challenge, yes.
Yeah.
Making it practical and accessible.
Okay, let's get into the fuel itself, the macronutrients. Carbs, proteins, fats, carbs first.
Sure. As you said earlier, they sometimes get a bad press, but they are the body's preferred energy source, 4 kilocalories per gram.
So primary fuel, brain food, microglial.
Absolutely. Glucose from carbs is vital for the brain and for muscles during activity.
But there's a difference, right? Simple versus complex carbs.
Big difference. Simple carbs are your basic sugars, monosaccharides like glucose and fructose.
Fruit sugar, blood sugar.
Right. And disaccharides like sucrose, table sugar, and lactose in milk. They give quick energy.
And complex carb.
Those are polysaccharides. Starches like in potatoes and grains and fiber.
Ah, fiber, the indigestible part, but still super important.
Incredibly important. Even though we don't get calories from it, you've got insoluble
A
fiber.
roughage helps things move along.
Exactly. Keeps the digestive system regular. And then there's soluble fiber, which dissolves in water.
What does that do?
It helps regulate blood sugar, can lower cholesterol. Think oats, beans, apples. So complex carbs give you more sustained energy, plus fiber benefits.
Okay, good distinction. Now, proteins, also 4 calories per gram, but their main job is different.
Yeah, think of protein as the building and repair crew. Essential for growth, maintaining tissues. It forms collagen, hormones, enzymes, immune cells. It's everywhere.
And it's made of amino acids. Some we have to eat, some our bodies can make.
Correct. Indispensable amino acids like histidine, lysine we must get from food. Dispensable ones, alanine, asparagine our bodies can synthesize if needed.
And that relates to complete versus incomplete proteins.
It does. Complete proteins, usually from animal sources like fish, poultry, eggs, milk, but also soy, have all those indispensable amino acids in good amounts, high quality,
And incomplete.
mostly plant sources, grains, nuts, legumes, vegetables. They might be low in one or more indispensable amino acid.
But you can combine them, right? Like rice and beans.
That's the concept of complementary proteins, yes. Combining different plant foods over the course of the day can give you the full profile.
What about nitrogen balance? You hear about that sometimes.
That's basically a measure of protein synthesis versus protein breakdown. Positive balance means you're building more protein than you're breaking down. Think growth, pregnancy, healing.
And negative.
That happens during illness, starvation, severe stress. The body's breaking down more protein. And importantly, if you eat enough carbs for energy.
The body doesn't need to break down protein for fuel.
Exactly. It's called protein sparing. Carbs spare the protein to do its building and repairing jobs.
Makes sense. Okay, last macro. Fats, lipids, the most calorie-dense one.
Yep, 9 calories per gram. Primarily triglycerides made up of fatty acids.
And we have different types here, too. Saturated, unsaturated.
Right. Saturated fats, usually solid at room temp. Think butter, fat on meat. Unsaturated fats, usually liquid. Think olive oil, vegetable oils. These can be monounsaturated or polyunsaturated.
Are there essential fats, like essential amino acids?
Yes, there are essential fatty acids we need from our diet because our bodies can't make them. Linoleic acid, omega-6 is one, found in vegetable oils, nuts, seeds.
And generally, animal fats have more saturated, plant fats more unsaturated.
That's a general rule, yes.
Yeah.
Though there are exceptions, like coconut oil being high in saturated fat.
Okay, that covers the big three. But we can't forget the support team. Micronutrients and water. Water seems obvious, but maybe it's more complex.
It's absolutely critical. Makes up, 60-70% of our body weight? Maybe more depending on lean mass. Every single cell needs it to function.
And we get it from drinks, obviously, but food, too.
Oh yeah, lots of foods have high water content, fruits, vegetables especially. It's all about balancing intake with output, sweat, urine, breathing even. And when you're sick, your needs can shoot up.
Good point. Then vitamins, organic compounds, catalysts.
Exactly. They don't provide energy directly, but they're essential helpers for metabolic reactions.
And some are antioxidants, like beta-carotene, C, E. What do they do?
They help neutralize free radicals, unstable molecules that can damage cells, so they have a protective role.
And there's a key difference between fat-soluble and water-soluble vitamins.
Huge difference in how the body handles them. Fat-soluble A, D, E, K can be stored in body fat.
So you don't need them every single day, but you could potentially get too much. Toxicity risk.
Correct. Water-soluble vitamin C and the B complex aren't stored in large amounts. Excess usually gets flushed out in urine.
So you need those more regularly. Daily intake is important.
Generally, yes, you need a consistent supply.
Okay. And the last support category, minerals. Inorganic this time.
Yeah, inorganic elements also acting as catalysts. We need macrominerals like calcium, phosphorus, potassium in larger amounts, over 100 milligrams a day.
And microminerals. Trace elements.
Those we need in smaller quantities, less than 100 milligrams a day. Think iron, zinc, iodine, selenium. Still vital, just needed in tiny amounts.
What kinds of jobs do minerals do?
All sorts. Maintaining pH balance, bone health, nerve function, fluid balance. And some, like selenium, also function as antioxidants, interestingly.
Fascinating. So we've got the fuel and the support crew. Let's follow the food. Digestion and absorption. How does it all get broken down?
It's a two-pronged attack, really. Mechanical digestion, chewing, stomach churning, mixing in the intestines.
Breaking it into smaller pieces.
Right, and chemical digestion, which uses enzymes to break down the large molecules, carbs, proteins, fats, into smaller ones the body can actually absorb.
And this happens all the way down the GI tract, mouth, stomach, intestines.
Pretty much. Starts in the mouth, salivary amylase begins carb digestion. In the stomach, acid and pepsin start tackling proteins.
But the small intestine is the main event.
Definitely. That's where bile from the liver helps break down fats, and a whole cocktail of enzymes from the pancreas and the intestinal wall finish the job on carbs, fats, and proteins.
It's like a disassembly line.
A very efficient one. Each part esophagus, stomach, small intestine, large intestine, plus helpers like the gallbladder, liver, pancreas, has a specific role.
So once it's broken down into tiny molecules, glucose, amino acids, fatty acids, what happens? Absorption.
Yes, primarily in the small intestine. And its structure is perfectly designed for this.
Villi, those finger-like things.
Exactly. Villi, and even tinier microvilli on them, create this huge surface area, like massive. Think of a tennis court spread out inside you. It maximizes contact between the nutrients and the intestinal wall.
Wow. And how do the nutrients get across that wall?
Various ways. Some just diffuse passively. Water moves by osmosis. Others need active transport, which uses energy. Some larger bits might use pinocytosis, where the cell membrane engulfs them.
Where do they go after being absorbed?
Most nutrients, carbs, proteins, minerals, water-soluble vitamins, get absorbed into the capillaries and go straight to the liver via the portal vein for processing.
And fats.
Fats take a different route. They mostly get absorbed into the lymphatic system first, bypassing the liver initially, and enter the bloodstream later.
And water absorption, does that only happen in the small intestine?
Mostly in the small intestine, but the large intestine absorbs a significant amount of the remaining water, helping to form solid waste.
Okay, so nutrients are absorbed, now the body has to use them. That's metabolism.
Metabolism is the sum of all the chemical processes in the body. It's broadly divided into anabolism.
Building things up, like muscle.
Right. And catabolism, breaking things down, like breaking down glucose or fat to release energy.
Can you give an example with carbs?
Sure. Glycogenolysis is breaking down stored glycogen in liver and muscles into glucose for energy. Glycogenesis is the opposite, building glycogen stores from glucose when you have extra, and gluconeogenesis is making new glucose, maybe from amino acids if your carb intake is very low.
The body is always trying to keep things balanced.
Always managing energy supply and demand.
And finally, what isn't absorbed needs to leave. Elimination.
Right. The remaining undigestible material, now called chyme, moves into the large intestine, water gets absorbed, bacteria work on some of the leftovers, and eventually feces are formed.
Made of undigested food, old cells, bacteria.
Yep, and that gets eliminated from the body.
Phew, quite the journey. Now, how do we figure out what and how much to eat? Dietary guidelines. Let's start with DRIs, dietary reference intakes.
Okay, DRIs are the big umbrella term for nutrient recommendations set by scientific bodies. They're based on age, gender, life stage.
And they include different levels, RDA, AI.
Exactly. There's the estimated average requirement, EAR, meets needs for 50% of people. The recommended dietary allowance, RDA, aims to cover needs for almost everyone, about 97–98%. That's usually the main goal for individuals.
What if there isn't enough evidence for an RDA?
Then they set an adequate intake, AI, which is more of an estimate based on observed intake in healthy populations. And there's the tolerable upper intake level, UL.
The maximum safe amount.
Pretty much. The highest daily intake likely to pose no risk of adverse health effects for most people. Good to know for supplements, especially fat-soluble vitamins.
So DRIs are the science. What about the more practical food guidelines, like the dietary guidelines for Americans?
Those translate the science into broader advice on eating patterns. The 2020-2025 guidelines have 4 main themes.
Which are?
Following a healthy dietary pattern at every life stage. Customizing choices based on preferences, culture, budget. Focusing on nutrient-dense foods to meet needs within calorie limits.
Nutrient-dense meaning lots of nutrients for the calories.
Exactly. Fruits, veggies, lean proteins, whole grains. And the 4th guideline is limiting foods high in added sugars, saturated fat, sodium, and also limiting alcoholic beverages.
They give specific recommendations too, don't they? Like half your grains whole.
Yes, lots of specifics. Variety of vegetables from all subgroups, whole fruits, making at least half your grains whole grains, variety of protein sources, including plant-based ones, and food safety is always in there too. Clean, separate, cook, chill.
Then there's My Plate, the visual guide.
Yeah, the USDA's My Plate is a really simple visual reminder of how to build a balanced plate. Half fruits and vegetables, about 1/4 grains, preferably whole, 1/4 protein plus dairy on the side. Easy to picture.
And lastly, the daily values on food labels. How do they fit in?
Daily values, DVs, are what you see on the nutrition facts panel. They're set by the FDA, mostly based on a 2,000-calorie diet, to give consumers a quick reference point.
So like a percentage of what you should aim for in a day?
Kind of. They provide context. They use reference daily intakes, RDIs, for vitamins, minerals, and daily reference values, DRVs, for things like fat and sodium. They're less personalized than DRIs, but more practical for comparing foods at the grocery store.
Okay, that clarifies the guidelines landscape. Now, a big theme is that needs change across the lifespan. Let's start young. Infants through school age.
Huge changes here. Infants grow incredibly fast, so they have very high needs for energy, protein, vitamins, minerals relative to their size. Breastfeeding is the gold standard, recommended exclusively for about 6 months by the AAP.
What happens as they become toddlers and preschoolers?
Growth slows down a bit, but good nutrition is still vital. Toddlers can become picky eaters, which is a challenge. And there's a risk of milk anemia if they drink too much cow's milk instead of eating iron-rich foods. Preschoolers might eat better, but habits are forming.
And school-age kids.
Growth is steadier, but concerns shift, maybe skipping breakfast, diets high in fat, sugar, salt. Childhood obesity is a major concern linked to health problems later on. The CDC tracks this closely.
Then comes adolescence, another growth spurt.
Big time. Energy and protein needs jump up again. Calcium is critical for peak bone mass development. Iron needs increase, especially for girls starting menstruation and boys building muscle mass.
But it's also a tricky time for eating habits, isn't it?
Very tricky. Body image concerns, desire for independence, peer pressure, fast food, fad diets, they can all influence choices, sometimes negatively. There's a risk of nutrient deficiencies or even eating disorders like anorexia nervosa.
What about teen athletes?
They need even more energy, particularly carbs, more protein for muscle repair, and really need to focus on hydration. Parental influence is still important, but often waning. And teenage pregnancy poses unique nutritional risks too.
Okay, moving into young and middle adulthood needs kind of level off.
Generally, yes. Growth stops, so the focus is on maintenance and preventing chronic diseases. For women, though, adequate iron and calcium remain important considerations.
And pregnancy and lactation.
There's big exceptions. Nutrient needs increase significantly during pregnancy: protein, calcium, iron, and especially folic acid, which is crucial early on to prevent neural tube defects in the baby.
Lactation requires even more energy.
Yes, producing breast milk takes a lot of energy, so calorie needs go up, as do protein needs and requirements for certain vitamins and fluids.
And finally, older adults. What are the key nutritional considerations then?
Energy needs usually decrease because metabolic rate slows down and activity levels might drop. But importantly, their needs for vitamins and minerals generally don't decrease.
So they need more nutrient-dense foods, getting the nutrients without excess calories.
Exactly. But many factors can make this difficult. Changes in taste and smell, chronic illnesses, multiple medications, which can affect appetite or nutrient absorption.
Drug-nutrient interactions.
Yes. Cognitive issues like dementia, dental problems, socioeconomic factors like limited income or mobility, even just a reduced sense of thirst can impact their intake.
What nutrients are particularly important for this age group?
Protein is key to help prevent muscle loss, sarcopenia. Calcium and vitamin D are crucial for bone health. There's even a MyPlate for older adults adaptation that emphasizes these points. And sadly, food insecurity is also a risk for some older adults.
It's a lot to consider. Beyond these life stages, people follow different eating patterns for various reasons too, right? Religious, cultural, vegetarian.
Absolutely. Food is deeply tied to culture and religion. Think about dietary laws in Judaism, kosher, or Islam, halal, fasting periods in Christianity, vegetarianism in Hinduism. Cultural beliefs, like hot-cold food theories, also play a role.
And vegetarian diets come in different forms.
Yes. Ovo-lacto vegetarians eat eggs and dairy. Lacto-vegetarians eat dairy but not eggs. Vegans eat no animal products whatsoever.
Can these alternative patterns be healthy?
Definitely, if they're well planned. A vegan diet, for example, needs careful attention to ensure adequate vitamin B12, vitamin D, calcium, iron, and zinc, but any pattern can be healthy with balanced intake.
Okay, let's shift focus to assessment. How do healthcare professionals, especially nurses, figure out if someone has a nutritional problem?
Assessment is critical. Nurses play a huge role here. It involves understanding digestion, nutrient needs, but also the individual's unique situation, their habits, preferences, challenges.
It requires critical thinking.
Absolutely. You need your knowledge base, but also awareness of the environment, your own experience, professional standards, and the right attitude, being curious, responsible, disciplined.
And it follows the nursing process: assessment, diagnosis, planning, implementation, evaluation.
Correct, a systematic approach.
So the assessment part. How important is catching malnutrition early?
Incredibly important. Malnutrition, especially in hospital patients, is linked to higher readmission rates, mortality, and costs. Early screening and assessment are key.
And it's not just about numbers, right? You mentioned the patient's perspective.
Vital. Understanding their preferences, beliefs about food, expectations for care, seeing it through the patient's eyes, makes any plan more likely to succeed.
How does screening work? Are there specific tools?
Screening is usually a quick first step to identify risk. Tools like the Subjective Global Assessment, SGA, the Mini Nutritional Assessment, MNA, specifically for older adults, or simpler malnutrition screening tools, MSTs, are used.
What kind of things do they look for?
Key risk factors. Has the patient lost weight unintentionally? Have they had a poor appetite or reduced intake? Are they on a modified diet? Do they have symptoms affecting eating like nausea or pain?
If screening shows a risk, then comes more detailed data collection.
Yes, a thorough nursing history about eating habits, lifestyle, medical conditions. A physical examination looking for signs of deficiency, skin, hair, nails, mouth, muscle mass.
And measurements. Anthropometry.
Right. Weight changes are a key indicator, though you have to be careful about fluid shifts masking real tissue loss. Registered dietitians, RDs, might do more detailed measurements like mid-arm circumference or skin fold thickness.
What about lab tests?
Labs can help. Plasma proteins like albumin and prealbumin can reflect protein status, but they're also affected by inflammation and hydration, so you interpret them cautiously. Nitrogen balance calculations can show if protein breakdown exceeds intake. And of course, a detailed diet history asking about usual intake, preferences, difficulties is essential.
You also need to consider the environment.
Definitely. Does the person eat alone? Can they shop and cook easily? What's the mealtime atmosphere like? Social and environmental factors matter a lot.
One specific problem mentioned is dysphagia, difficulty swallowing.
Yes, dysphagia is serious. It can be caused by many things: stroke, neurological disorders, cancer, even just aging sometimes.
And the risks.
Big risks. Aspiration food or liquid going into the lungs, potentially causing pneumonia. Also dehydration, malnutrition, weight loss.
Are there warning signs?
Yes. Coughing or choking during or after eating. A wet or gurgly voice quality, needing to clear the throat often. Food pocketing in the cheeks. Slow or effortful chewing. Screening is vital, often involving a speech-language pathologist, SLP.
Okay, let's bring this together with the case example. Mrs. Cooper, what was her situation?
She's an older adult, recently widowed, living alone, taking several medications, reported eating poorly, maybe one small meal a day, lost weight, low BMI, physical signs like pale gums, thinning hair, feeling fatigued, isolated, possibly depressed.
A complex picture.
Very. Her assessment points towards impaired low nutritional intake, likely due to a combination of grief, depression, social isolation, maybe medication side effects, possibly reduced appetite or energy to prepare food. Other diagnoses like fatigue or difficulty coping could also apply.
So, based on that, you plan interventions, setting goals.
Yes, realistic goals, like maybe aiming for a specific weight gain over time, or Mrs. Cooper verbalizing understanding of a healthy eating plan and committing to try it.
And choosing interventions requires that same critical thinking.
Absolutely, drawing on knowledge, standards, experience, considering her specific situation preferences, budget, culture, home environment, maybe involving family or community resources.
What kind of interventions might help someone like her?
Health promotion is key education on balanced nutrition, maybe using My Plate for older adults. Practical tips like meal planning on a budget, maybe suggesting nutrient-dense snacks or small, frequent meals. Addressing appetite, making the environment pleasant. Good oral hygiene before eating, maybe eating with others if possible.
What about in a hospital setting? Advancing diets, assisting with feeding.
Right. Hospitals often use a stepwise approach to reintroduce food, clear liquids, full liquids, soft diet, regular diet, as tolerated. Therapeutic diets, low sodium, diabetic, gluten-free are common too.
And if someone needs help eating?
Safety, independence, and dignity are paramount. Proper positioning, especially crucial for dysphagia risk. Checking food, texture, viscosity. Feeding slowly. Using adaptive equipment if needed, like special utensils or plates. For visual impairment, the clock face method helps them locate food.
What if someone just can't eat enough by mouth, but their gut works? Enteral tube feeding.
That's the next step, yes. Enteral nutrition, EN, delivers liquid formula directly into the stomach or small intestine via a tube. It's preferred over intravenous nutrition if the GI tract is functional.
Different formulas for different needs?
Many types: polymeric, standard, whole nutrients, modular, single nutrients added, elemental, pre-digested nutrients for impaired absorption, specialty formulas for kidney disease, diabetes, etc.
How is it given?
Can be intermittent boluses, like meals, or continuous drip infusion. Depends on tolerance and location of the tube.
And ensuring the tube is in the right place is critical.
Absolutely essential. X-ray is the gold standard for initial confirmation. Bedside checks often involve testing the pH of fluid withdrawn from the tube should be acidic if it's in the stomach. Regular flushing helps prevent clogs.
Are there complications?
Potential complications exist. Aspiration, a major risk, diarrhea, constipation, tube occlusion, irritation at the insertion site. Careful monitoring and management are needed. Different tubes are used too. NG tubes, nasogastric, short-term. G tubes, gastrostomy, into stomach, long-term. J tubes, jejunostomy, into small intestine. And safety connectors like ENFit help prevent wrong connections.
Wow, it really highlights the need for teamwork. Nutrition isn't just one person's job.
Not at all. Effective nutritional care requires collaboration. The registered dietitian, RD, assesses needs, develops the plan. The speech-language pathologist, SLP, assesses swallowing. Occupational therapists, OTs, help with self-feeding adaptations. Pharmacists check for drug-nutrient interactions. Nurses coordinate care, monitor, educate, administer feedings.
And this collaboration needs to extend beyond the hospital.
Crucial. Integrating nutritional support into discharge planning ensures continuity of care. Does the patient need home health support? Meals on wheels, ongoing RD counseling, all that needs to be considered.
Going back to Mrs. Cooper, her plan would need that team approach, considering her preferences, finances, social situation.
Exactly. Patient-centered, maybe involving an RD referral, breaking down education into short sessions due to fatigue, exploring community resources for social connection or meal support.
So, wrapping up this deep dive, what's the core message, if you boil it all down?
I think it's that nutrition is incredibly dynamic and interconnected. It's physiology, yes, but it's also environment, culture, psychology, economics. Understanding these links empowers you to make better choices for your own health.
Were there any sort of surprising facts or details that jumped out during our discussion?
Oh, several things. The sheer energy density of fat, 9 calg. The huge variety of roles protein plays. Fiber's importance despite having no calories. How much water percentage varies. The antioxidant function of certain vitamins. Just how complex digestion is, how guidelines evolve. The specific needs at different life stages, especially older adults. And how much medications and social factors can impact intake. It's all quite intricate.
So what does this all mean for our listener? What's the practical takeaway?
It means you now have a solid foundation for understanding your own needs and making sense of dietary advice. Hopefully, you feel better equipped to navigate the information overload and make informed food choices. But also, recognize that it is complex and individual needs vary. Don't hesitate to seek personalized advice from professionals like RDs or your doctor.
Right. And finally, a thought to leave you with. Knowing how intricate nutrition is and how many factors influence it, what's maybe one small evidence-based change you could make starting today to support your long-term well-being? And perhaps what specific questions about your own nutrition might be worth exploring further with a professional.
Good questions to ponder.
Thanks for taking the deep dive with us today.